Hello, I'm Rob Fromberg with Kaufman Hall. We're pleased to welcome you to Kaufman Hall's webinar on creative affiliations for success in healthcare's new era. Leading the webinar today is Andre Maksimow. Andre is a senior vice president with Kaufman Hall, and he has more than 20 years of experience in mergers and acquisitions, private equity, and operations. Andre's expertise includes hospitals, health systems, and post-acute care. Just a few housekeeping items before we start. Participants are in listen-only mode during the session. If you would like to ask a question, you can do that using the question box to the right of your screen. We welcome your questions and we'll make sure to answer them later in the session. You can also access the materials from this webinar through the interface on your screen, and after the webinar, we'll send you an email to access the recording of the session and other material. With that, I will turn the presentation over to Andre.
Thanks, Rob, and thank you everyone for being able to attend this webinar. As Rob mentioned, we're going to be focusing on creative affiliations, and what I thought to kind of open this up in terms of an agenda, what we'd really like to cover here today is, one is kind of what are the driving factors here driving creative affiliations? What is it that's kind of causing folks to think a little bit differently right now in terms of how they affiliate with other health systems, including other providers that they may need to either round out the continuum or their capabilities. And then next, what we'd like to do here is we're going to go through some case studies of real transactions that have occurred, kind of thinking through some of the drivers and some of the elements that may kind of vault them into this creative category and the things they're trying to accomplish. And then finally wrap it up with some concluding thoughts. So that's what we hope to accomplish today, and let's just kind of jump right into it. So on page 3, kind of discussing, this is really kind of where things start from Kaufman Hall's perspective in terms of driving creative affiliations and a lot of the work that we do right now. On the left-hand side, in terms of the old business model, you know, the perspective was always that the hospitals were kind of at the top level, so to speak, and the main interface between the hospitals and the patients were the doctors, and that was the ecosystem that occurred or had been continuing, and the whole goal there was volume, volume, volume. The more doctors you have, the more volume you could derive, the more patients that you capture that volume from. You make a lot of profits, life is good. Now that's through a lot of different factors, both governmental and also by private enterprise, namely employers, that model is shifting right now. And what we believe, for Kaufman Hall's perspective, is that really at this point in time, the customers really sit on top. And then what we believe the new healthcare business model is really starting to evolve into is this notion of a health company, where it is an aggregator of contents, including both the hospitals, doctors, outpatient care, post-acute, what have you. So what you'll see here is the real driving differences between the two models is, whereas hospitals were kind of the pinnacle and believed to be the profit center, as things evolve now, hospitals are really more viewed as a cost center, and the real value-added linkage is that between the health company and the customers, whether it be payers or patients. So this, again, is kind of the foundational elements here of what's driving our thought process in terms of creative affiliations and for some of the work that we've seen done. On page 4, to kind of recap what Kaufman Hall believes are some of the key success factors right now for the new business model. You know, how is it that the new health company is going to evolve? From our perspective, at least, number 1 and number 2, market essentiality, strong local brand, in addition to size and scale and financial strength. Probably characterize that as key success factors, not only for the new business model, but likely the old as well. Never hurt to have that strong local brand and or financial strength. When you really look at numbers 3 through 8, in terms of these other capabilities, these are things now that are really going to be critical to the extent that you are the healthcare company, which, by the way, we don't have a firm point of view in terms of what that health company may be. Could be an insurance company, could be a health system, could be an IPA or some variation thereof, or frankly, it could be a company that currently does not exist right now that will be, you know, formed for the future. And that permutation of the healthcare company, what we believe are some of the critical components include that ability to really have an integrated physician platform and integrated provider base aligned as well. A critical component now as things go forward. Obviously, IT and analytical capabilities. The new currency, if you will, for success. Patient access at multiple points. Not only is it going to be at the hospital level, but obviously ambulatory locations, urgent care, various hours of the day, really enabling patient access through all elements, including not limited to telehealth and mobile apps. Consumer engagement, certainly that's an important element here as well, as consumers and patients become more responsible for their healthcare choices, both from a financial and outcome perspective, and more transparency becomes the norm. All of a sudden, engaging with consumers and really understanding consumer behavior, which heretofore has really not been a primary focus of hospitals and health systems, just given the fact that, again, the majority of the focus is really on the payer, not necessarily the patient in the old business model. Rounding this out, risk-based contracting capabilities, whether or not it's teamed up with an insurer or having it done at the local health system level, knowing risk-based contracts, being able to implement them, being able to manage them, and evolve with them as health systems likely continue to take on increased risk. That element here is going to be critically important. And then finally, a total cost focus. And what that means is, not only some of the traditional costs and focuses on back office and administrative synergies and reductions, but really now starting to look forward on clinical variation, thinking of total cost of care and those elements. And again, kind of hearkening back to the hospital is really going to be that cost center, not necessarily the profit center forward. Moving along, kind of juxtaposing, if you will, the traditional versus the creative affiliation route. From our perspective, I guess the best way to characterize some of the traditional transactions that have occurred is really it's more of a financial focus driven by distress. I characterize most of them as acquisitions, whether or not they're for-profit or not-for-profit. And the main focus really has been, from a synergy perspective, a lot to do with pricing and also back office improvements. And in the traditional model, frankly, location and or geography may not have been as important because, again, having kind of the level of market scale or relevance wasn't necessarily as critical as it is here today. So you kind of think about the marketplace, many of the for-profits being able to kind of have a national footprint, but not necessarily having the local market scale or relevance has been the norm. But now, as things are evolving right now and creative affiliations are becoming more the norm, the real financial or the real deal currency, if you will, is now really a lot of it has to do with these core competencies that I just described. Overall intellectual capital, scale and market essentiality, IT and data analytics, everything to do with physicians, whether it be the platform, integrating, recruiting, aligning, etc. And then ultimately, as all these pieces are put together, really improving and bettering, the overall delivery network, optimizing it, improving the efficiencies, access, and then ultimately, as far as this whole notion of creative affiliations goes, a lot of this has to do also with the notion of covered lives. So the currency and the kind of some of the metrics, less utilization, more covered lives, population base. What is it that the health system, if you will, really controls or is responsible for the total cost of care for a certain population? And that's where a lot of the creative affiliations, at least that we witnessed, seem to be heading in terms of the real focus and core elements. So with that, looking at some of the empirical trends and maybe supports this view is that on the left-hand side, in terms of understanding hospitals and health systems, from our perspective, in terms of the traditional, hospital or the local community hospital being consolidated into a health system, we're frankly probably in the seventh inning, if you will, of that consolidation going on. Right now it's about 66% of all hospitals are in health systems. many of the hospitals may never ultimately wind up in a health system, whether it be for specific market conditions or structural elements that prevent or don't necessarily necessitate a health system combination, and or some of these hospitals may not be in existence. So, in terms of consolidation 1.0, if you will, that first round of consolidating out local community hospitals, smaller organizations, likely in the seventh inning. But now, as you kind of look at where we're seeing much more of the creativity and much more of these elements that I just described being focused upon is larger deals with targets that are over $1 billion. So these are targets that, again, don't necessarily need the capital, really looking for capabilities, looking to kind of advance or accelerate their strategic plans in population health. And if you look at the chart here, in terms of the trends, it's been around that 5 to 6 level for quite a few years right now. And in 2017, at least through the 6 months, you see about 5. I'm not sure it's fair to annualize it to 10, but you're seeing kind of, at least recently, some pickup right now in terms of larger deals. Some of them including Dignity, CHI, Hackensack, Meridian in New Jersey, Pinnacle, UPMC in Pennsylvania, and Beth Israel Deaconess and Lay Clinic in Massachusetts. So those are some examples and kind of a rehashing some of the empirical elements here that at least seem to support some of the views that we're discussing. Page 7, very similar statistic here in terms of more empirical evidence. What this really tells you here is that, as you see, starting really with 2014, many of the deals, again, which kind of is confirmed by this graph here, is not really necessarily all about the capital. It's really about these other capabilities and other deal currency points. And what you see here is, with the sellers, the target credit ratings at A- or above, that's in that 7 to 10 level. And at least if you continue with the kind of the trajectory, if you will, for the last couple of years, that seems to be increasing. And we likely believe that in consolidation 2.0, that will continue to increase and accelerate. On page 8, I'd like to describe kind of a specific case study. So this is a partnership that I had the opportunity to work on. This is the combination of, or the merger of Geisinger and Atlanticare. Geisinger, for those not familiar, very strong health system in Pennsylvania, known for its population health, integrated health system with a health plan. Atlanticare was a, give or take, about an $800 million health system, 2 major hospitals, extensive ambulatory care network located in and around Atlantic City. So those are the kind of grounding us in terms of geography. And I think one of the key things that kind of jumps out of you in terms of this particular partnership, which was fully integrated change of member substitution deal, is that the overall distance. It's about 150 miles from where Geisinger's epicenter was to Atlanticare. So clearly, geography and local, well, at least local market scale was not necessarily the driving force here. There were a lot of different reasons for why Atlanticare and Geisinger came together, and I'd like to kind of briefly go through these, but obviously geography was not one of them. If you look at some of the key kind of goals relative to this particular partnership, really from Atlanticare's perspective, there's probably kind of 2 major categories or 3 major categories of goals in the following order. One was really being able to accelerate an insurance capability and really having the care delivery network optimized and integrated such that an insurance capability that they were prepared to take on risk and full premium risk. From their perspective, that they always wanted to capture more and more of the premium dollar and in fact immunize themselves against some of the threats and competitive threats of other insurers and other payers in the marketplace. So what that really portended then is that really in terms of their laundry list of items, much of it had to do with capabilities. The second kind of major goal of Atlanticare I would characterize as autonomy. This was a fairly healthy or actually very strong credit, A+ type credit, had operating margins for the prior 3 years prior to the deal, in excess of 3%, EBITDA margins 11% plus, days cash on hand 250 plus for the last 3-4 years. So certainly it was not about the capital in and of itself in terms of a combination with Geisinger. So autonomy and being able to kind of control some of their own destiny was an important element of any particular partnership. And then lastly, I think to make sure that everyone understands, well, capital was not necessarily the driving force. Certainly Atlanticare, they were cognizant of what was going on in Atlantic City, some of the declines. They had fairly reasonable level of exposure to Atlantic City and all the goings on there with casinos and some of the threat to this casino industry coming from Pennsylvania and other out-of-state providers. So, the notion of a financial backstop or some ability there, if things did really go wrong, that they would have an ability to, rely on another partner was an important element. Not only in so far as, being able to remain viable, but the other element of this too is that with the financial backstop, they'd be in a much better position to take on risk and take on, certain operational risks they otherwise would not have if they were independent. So it kind of gave them some of that freedom, if you will, to do some more experimentation and advance the organization without worrying about, what if type scenarios according of Atlantic City and some of the market. From a Geisinger perspective, it's our belief that some of their key goals and objectives were, they were really at this point in time looking to continue to grow the system. And one of the things that, at least from Kaufman Hall's perspective, what Geisinger's goal was is that while very effective in the Danville area in terms of their integrated health plan and care delivery system, Geisinger, at least at that point in time, had not been able to prove out their overall kind of capability and their philosophy and operating philosophies in other markets. So certainly Atlanticare, with that 150-mile difference in geography, would be a great case study here that would kind of accelerate that proof of concept and be able to convince others that certainly the Geisinger health system integrated care health plan, care delivery, clinic type model was one that could be replicated and proven out in another location without the benefit of their market scale in Danville. And the other elements here is that while they were continuing or thinking about doing this, they wanted to make sure that there was a partner that was non-dilutive and really shared in both their vision, but also understanding, given some of the geography issues or the breadth of the geography, they really wanted a strong management team to make sure that the management team continued on with some of the great work that's been going on, and really kind of were the folks that would champion and spearhead a lot of the initiatives. Not to suggest that 150 miles is something you can't get over, but same token, it's not the same as having something that's 10 to 15 miles away in terms of being able to meet frequently, just the overall communication, etc. So what makes this particular deal really creative, or as we kind of characterize as a creative affiliation? Really from our perspective, we have not seen many deals like this structured beforehand, but what we in essence were able to do was default to Atlanticare really retaining most of the autonomy related to deployment of capital, HR issues, operating budgets, being able to make certain investments. They would be able to continue to do that for a period of 10 years. But the real kind of the guardrail, if you will, was that it would have to be, Atlanticare would have to maintain a certain level of financial performance. And those key guardrails really were tied to operating income and days cash on hand. So the philosophy was, okay, if Atlanticare can continue performing to a level that Geisinger had felt comfortable with, then go ahead and continue with your plan. There were certain reserve powers that were retained by Geisinger. You had to meet the Copper World test, but nevertheless, though, we pushed the boundaries of control, and the way that the key kind of lever, if you will, or the bridge to be able to do that is this notion of these performance metrics that were integrated within the agreement. So at least from a Kaufman Hall perspective, we felt that was a pretty novel approach here to try to bridge the key transaction goals and objectives for the parties. And with that, there was a bit of a kind of a quid pro quo that occurred here as well as we continue to go through this. As I mentioned before, the transaction objectives, the number one consideration was making sure that many of these capabilities that Geisinger had described to AtlantiCare would be made available to AtlantiCare, including, not only the health plan capabilities, but care management protocols, physician management, just the ability to frankly start up a health plan, knowing that the health plan, at least in its beginning stages, would have to be, something in a relatively small level of 25 to 50,000 lives. So the way we kind of we thought about this was, okay, while AtlantiCare would have these performance metrics that they would need to adhere to retain their autonomy, we also want to make sure that Geisinger was accountable to AtlantiCare for delivering on all these different capabilities and promises. And unlike capital, which is fairly easy to measure, whether someone invested or not, these elements are a little bit more difficult to kind of measure objectively. And what we came up with was a series of metrics, both financially oriented in terms of synergy levels that need to be achieved, also quality metrics and levels of and other metrics that would better define success, if you will, and what Geisinger promised AtlantiCare in terms of the partnership. And ultimately, through a fairly structured deal, as I'm describing right now, the key takeaways here are that Geisinger was able to add this $700 to $800 million strong credit system without any kind of significant dilution or capital commitments, because of AtlantiCare's the marrying, if you will, these goals and objectives, and what we like to believe is a real recognition of what was important in the deal and what wasn't. And focusing on crafting and structuring the deal such that both parties were happy with the outcome, and not necessarily being tethered to some of the historical philosophies that might have ensued here. Just relative order of size, Geisinger, at the time was probably a $3 billion plus type system. AtlantiCare about 700 million. If you looked at this from far away, you might have thought that, Geisinger gave AtlantiCare an extensive amount of capital. And for that, AtlantiCare essentially gave up a lot of its ultimate control. But that was really not the case. And given some of the creativity, both by AtlantiCare and Kaufman Hall, we were able to, and frankly, Geisinger's receptivity to really listen and say, okay, we're willing to do this a little bit differently than any of the other particular deals that we've done, because given the circumstances, given the goals and objectives and what we're all trying to accomplish, it really made sense to do so. So that's AtlantiCare. Moving on to the next particular transaction. This one here is, this is also one that Kaufman Hall was advisor on to Ascension. This involved Ascension and its Carondelet health network health system located in Arizona. And from a contextual standpoint, Kaufman Hall was retained. Ascension at this point in time felt as though that in this particular marketplace did not really have the level of scale and market relevance that it would need to continue to survive and prosper. And as such, as we stepped into it as Kaufman Hall and started marketing the opportunity to various different organizations, what really became fairly clear is that there's a couple dynamics that were going on. One is that Tenet and Dignity had already started a relationship, and we're starting at least the beginning stages of a statewide network, and they had a particular need, at least for this particular asset, to kind of continue to round out their network. Most of their health assets were located in the Phoenix area, but with this particular asset, this is located more in the Tucson area, and this would have been a nice addition to kind of aligning a statewide network for the purposes of risk contracting. And in terms of the actual deal goals and objectives, what's interesting about this particular situation is that the joint venture was structured such that essentially Tenet was the sponsor, if you will, of the deal. It retained a majority interest in Carondelet, the joint venture, after the fact. But Dignity Health also became a minority owner, again, to kind of line the interest over the entire statewide network. And very interestingly, at least to me, I did not work on this particular transaction. Ascension also retained a minority interest in Carondelet. Ascension at this point in time had no other assets or healthcare or clinical assets in the state of Arizona, yet also decided to retain a minority interest in this particular joint venture. So in terms of goals and objectives, a lot of them, Ascension, again, they felt as though that in this particular market, given the size, $400 to $500 million of revenue, given its relatively small relevance in the marketplace, very difficult for Carondelet, irrespective of any kind of capital commitments, synergies, back office improvements, etc., would be very difficult to survive over the long term in this market. Tenet, Dignity, looking at them, they had a real desire here to start structuring a statewide contracting statewide network to be able to start considering statewide contracts. And the Tucson market was a pretty nice tuck-in, if you will, to help round out their aligned provider network. And with that, again, some of the key principles here, both Dignity Health and Tenet obviously have ownership interest, but the interesting wrinkle here is that Ascension also retain an ownership interest. So looking at page 11, just to kind of straw out some of the boxes, if you will, of the deal and who owned what. Looking at this, so Tenet Healthcare and Dignity both owned interests within the joint venture that ultimately owns now Carondelet. Dignity holding a minority interest and Tenet owning the majority interest, and Ascension, despite the fact they have no other assets in the market, also retained a minority interest in Carondelet. And you notice here the Arizona Care Network, this is the beginnings, if you will, is that state contracting vehicle that was owned jointly by Tenet Healthcare and Dignity Health in Arizona. So again, from this particular instance here, in terms of creative affiliations and how this all came together, I think the real takeaway here is that unlike, perhaps some of the more traditional approaches here, Tenet decided that the way to go into this market was not alone. They really wanted to make sure that they were aligned with their partner for a much bigger purpose, which was ultimately positioning themselves for statewide contracting. And that's what I understand to be the key reasons why Dignity came along to stay in a minority partnership position in the joint venture. So ultimately, the goal here was not only to align the interests of making sure that the ACO is aligned, but ultimately having that aligned provider network. So you had investments both at the network or the contracting level, but then also investments at the provider level, so they would be fully aligned. In terms of Ascension, they retained that minority interest in Carondelet. My understanding is, in terms of why they considered retaining that interest, I never quite understood exactly why, but my understanding was that there were a couple different reasons. Where number one, there was the idea that potentially Ascension would continue offering certain shared services to the joint venture for some period of time. And in so doing so, they could maintain an alignment of interest with Ascension as that relationship continued on. But the other element of this as well is that from Ascension's perspective, at least, retaining the minority interest, all things being equal, Ascension is obviously in the healthcare, the health system business, and retaining an interest, although minority in nature, without having that level of control. Looking at this from a more of a kind of an investment, so to speak, rather than looking at this as an operating asset. They like the risk-reward dynamics in terms of how this is all being set up, in terms of what Tenet Healthcare and Dignity Health could bring to the table in terms of repositioning Carondelet to be not only much more relevant in Tucson, but to be part of that greater statewide contracting network I just described. So that is the Carondelet joint venture partnership. Hopefully that gives some perspectives in terms of how multiple kind of competitors can come to the table and figure out a partnership that makes sense for all parties and using a bit more of a novel approach. Last case study we're going to go into a fair amount of detail is this Vivity arrangement that was sponsored by Anthem out in California. This particular transaction, Kaufman Hall was not involved in. So much of the information we have here is based on public information and what we understand based on our relationships with the various providers. In terms of this particular arrangement, I think that the key thing to understand behind this arrangement was that the whole focus and the reason for this coming to being is that in this particular marketplace, and I guess knowing the California marketplace is kind of critical to understanding some of the whys of why this partnership came together. In the LA marketplace, some of the dynamics, very fractured or fragmented, if you will, provider landscape. Many of these providers could continue on with their own capabilities and and maintain their independence, indefinitely because of just some of the structural limitations of Los Angeles, i.e. some of the traffic concerns and the ability to go from area to area in a fairly small distances. Many of these providers, despite the fact some of them are community hospitals, have created advanced tertiary capabilities. So they're able to kind of retain, again, much of the local population would maintain or would continue to use these providers going forward. But the real kind of reason for this particular partnership was a focus on Kaiser, in particular the large employer market, where Kaiser, the integrated delivery system with both the health plan and the clinical assets, is a very formidable competitor in this particular locale. And as I understand it, kind of controlled somewhere in the range of 60 to 70% of the large employer market. And the notion here is that Anthem, together with these providers, thought, well, what's the best way for us to kind of come together so we could service some of these large employers, including, likes of CalPERS, Boeing, Disney, etc. What kind of network do we really need to have put together, and what kind of pricing would make sense in order to induce some of those large employers to consider switching from Kaiser to this new Vivity product, HMO product. So largely, when you kind of think about structure here as well, my understanding is that from a pure ownership perspective, Anthem owns 100% of Vivity, kind of the special purpose entity that was set up for this particular contracting vehicle. They own it. They also own all the systems surrounding Vivity in terms of interconnectivity, insurance claims reviews, etc. That's all owned by Anthem. But in terms of how alignment is created, each of the particular, main providers, if you will, were apportioned a certain amount of covered lives based upon their primary care networks within their, aligned physician groups, whether it be the foundations in those respective markets and or IPAs. So the idea here is, okay, as folks come on for the product, wherever these covered lives live, they get attributed to the primary care doctor. And in the particular locales here, talking about each of these providers, it kind of formed a pod, so to speak, in terms of capturing what the relative premium would be attributed to that pod versus the amount of expense from claims and otherwise that would inure there. And the basic premise here was, from each of the providers' perspectives, because of the fact that the target really was Kaiser, who again is the integrated provider, from a pricing standpoint, they're able to get fairly aggressive on the inpatient side, because ultimately, reducing inpatient pricing in order to induce some large group employers would not necessarily risk, cannibalizing some of the fees they otherwise receive from other insurers. So namely, again, Kaiser, given its insurance product, the captive insurance / closed model provider. If folks are taking insurance under Kaiser, then certainly all their utilization would flow through the Kaiser network. With these particular providers, if they are able to induce and bring over additional covered lives from Kaiser and bring it into the Vivity model, notwithstanding the fact they may need to discount significantly on the inpatient side in order to put out a pricing or an overall product price that makes sense, is able to induce large employers, all that inpatient volume, for the most part, is really incremental. So it's not as if they're kind of foregoing some other insurance carrier volume for this purpose. So that was kind of a key element from a structural standpoint, how Anthem's able to kind of offer some of these inducements and very competitive pricing in order to motivate some of the large group employers to transitioning over. And, in terms of, the overall size of the network, in terms of the overall scale of the amount of members, some interesting stats for folks to consider. I believe when in the first year of operations for Anthem, the total amount of covered lives they were able to achieve was about 24,000. The next question folks may be thinking about in the audience is, well, that's interesting, 24,000. How many of these members are really just the employees, if you will, the various systems? And that numbers are probably about 6,000 to 7,000 of the actual provider employees are part of that 24,000 that started in 2015. But at least what I was interested in, and what I understand right now, is that the product is actually gaining more and more traction there in the marketplace. It's not spectacular growth, but still evidences that this is a much more viable product in the marketplace than or at least a potential real competitor to Kaiser. The amount of covered lives that the Vivity arrangement now has in 2016 is about 35,000. You see some growth that's going on here right now. And I think it's important to understand too that in this context, much of the model right now is predicated upon the pod relationships and the providers being able to offer very compelling inpatient / facility-based fees for utilization. And the underpinning of that is that, candidly, much of that is incremental contribution margin that would come to the organizations. So heretofore, in terms of other opportunities, my understanding is, much of the interoperability investment has not really has gone on. That's opportunities that might come to fruition later as this organization builds out additional scale and covered lives are managed. Data aggregation, integration has not really occurred in earnest. Again, the simple reason is that the overall level of investment and financial opportunities probably just doesn't quite justify it at this point in time. Highly coordinated care across each of these providers. Again, in the LA landscape, probably not as important, but nevertheless, having that kind of coordinated care, one patient record going across each of these providers, being able to see or being able to be utilized by the providers or the physicians, something that might be an opportunity for the future. And then ultimately, being able to optimize not only some of the elements of care management, but perhaps there's other opportunities to rationalize some services across each of the providers. More to come on that. But ultimately, it's a very interesting affiliation or partnership that's been created right now. And it's really facts and circumstances. Much of this led to that partnership was really the specific market issues in LA and the competitive market for managed care companies and the fragmentation that really existed in terms of the main providers, both academic medical centers and community health systems in the local LA market. Looking at the next page, I thought it'd be interesting just to kind of give we were able to find this on the web and find out kind of what the HMO product looks like, at least in its most current form. This, I believe, is for a plan period from 7/1/16 to June of 2017. And you could see kind of what some of the drivers here are in terms of being able to offer that much more competitive price. So the things that we kind of looked at and honed in on is, if you notice the outpatient surgery side and also the hospital stay. So if you use an out-of-network provider, it's not covered, period. You can just imagine what the potential financial repercussions are for a potential member here to go to an out-of-network provider for either an outpatient surgery or hospital stay. And, on the flip side, in terms of the inducement, you can see here in using outpatient surgery, the way this plan design was structured, there's no cost share if you use an in-network provider on the outpatient surgery side. And if you have a hospital stay, fairly nominal copay related to an admission, and the physician or the professional fees associated with it were completely waived. There's no cost share surrounding that, as opposed to it being completely not covered if you use an out-of-network provider. So certainly from a plan design perspective, very organized according to the network that's created. Some real levers here to induce coverage or to induce covered lives to utilize the network that's been created, and kind of integrating this all from a financial perspective. From the perspective of this audience, kind of thinking about this and saying, okay, well, could something like this occur in my particular market? I guess things to kind of consider in this is that, again, within the LA marketplace, what you had was a lot of fragmented health systems and hospitals that really, in order to kind of offer a viable product for large employers, really need to come together. So that's one, major dynamic. The other one is that in this particular instance here, you had the incumbent competitor that held much of the large employer market, Kaiser. You have a situation where if even notwithstanding the fact you may consider discounting some of the fee-for-service pricing on the utilization, you're still much better off in this context since none of that volume was ever coming to you if Kaiser was the insurer. In your particular market, if you were to consider a relationship like this with an insurer, obviously one of the things to consider here is that, at least from a pure financial perspective, is you stand up a product, a narrow network type product, you reduce the pricing inherent within that product. Well, all the growth that may occur in that particular marketplace associated with your product may come at the expense of other insurers that have much richer pricing in terms of your facility fees and your professional fees. So something to really consider there. This is a unique situation where Kaiser, much of this was at the margin here, if you will, that was profitable, really profitable business to get much more involved in large group space and being able to offer that very competitive pricing to large group employers along with the network. And then finally, thinking about this in terms of the network benefits, a pure HMO product, is that something that your market really could stomach? This whole notion of completely not covering any sort of costs if using an out-of-network provider, at least in my particular location where I live in New Jersey, that's something that I think would have a lot of difficulty catching on in terms of a viable insurance product from the marketplace. So as the folks on this call particularly think about their particular market, that's another kind of key consideration as you evaluate all these different, you look at the creative partnerships I've discussed before, and also Vivity in particular. So hopefully that gives some rich texture here, if you will, to these particular affiliations, spawn some different thoughts on your end in terms of thinking about how to structure some of the transactions, and also thinking about, well, the extent that there needs to be affiliations, and given the fact that the focus is likely going to be on some of the new business model capabilities, core capabilities, how should we think differently, if you will, about some of these affiliations and how they might occur? So that was my hope here in terms of this particular webinar. And, as we kind of wrap this up right now, the new business model, no one knows what exactly it's going to be, but certainly there is a new business model that's being formed right now, because ultimately in terms of the old model and pricing, we've just come to an inevitable end, if you will. There's really not much left that can be done in terms of the pricing. So now everyone's got to think a little bit differently right now in terms of what the go-to-market strategy is and how you're going to take on risk. And as evaluating these, creative affiliations and thinking about partnering versus maintaining and continuing on your own, in our humble view at least, in terms of a health system, notwithstanding how large you may be, very difficult to do everything yourself, not only from a cost perspective and being able to scale up, different capabilities. Obviously, in this context, we talked about health systems, but the same notion really applies to many other different partnerships that might be going on with other types of providers. But just as important is really the speed to market. Things are changing pretty rapidly. We understand that different markets are changing at different levels or different, kind of acceleration, or at different velocity or speed, but nevertheless, things are changing pretty rapidly, and you have to kind of think about, when you think about that buy versus build type strategy, what is that speed to market? And then ultimately, irrespective of whether we call it creative affiliation or otherwise, and whether the currency now is capabilities versus capital, the whole notion of collaboration, but I believe at least, the true north of any particular successful partnership that's able to sustain for the long term is really making sure that the parties are able to align the long-term interests of both in the context of a deal. That's ultimately the glue that really keeps things together. Despite the fact there might be ways to have commitments and other structural elements within the definitive agreement, unless there really is that kind of long-term alignment of interest, whether it be financial or otherwise, partnerships, at least in our opinion, are very difficult to sustain over the long term. So that is all my prepared remarks for this particular webinar. I'll stop here now and perhaps kick it back to you, Rob Fromberg, for questions.
Thank you, Andre, and I hope the listeners will continue to submit questions. We have a handful. I hope we'll be able to get through them all. Let's start with this question, which is, are there any circumstances where these sorts of creative affiliations are stepping stones to a tighter affiliation? I assume that would mean like a full asset merger.
Sure. In these particular models, I think the answer is yes. Just using, let's say, Geisinger Atlanticare as an example. From a structural perspective, the deal actually only enabled a 10-year runway, if you will, for Atlanticare to maintain its autonomy for the most part. After the 10-year window, things would collapse, and Geisinger would ultimately be able to retain complete control subject to what they wanted to delegate to the local market. So the answer is yes, it can kind of morph into a more integrated model. And I think it really depends on the facts and circumstances and how maybe the goals and objectives of the original affiliation change.
Great. Here's a fairly straightforward question. One listener is asking you to define the copper weld test.
Okay. I'm going to probably defer to some legal folks here, but my general understanding is this is a court case involving I believe it went all the way to the Supreme Court. I'm not completely sure, but essentially the context was, can a subsidiary and its parent company be accused of collusion or antitrust behavior? And, after a lot of litigation over the matter, the name of the case was Copperweld, and essentially what it ruled was that, again, subject to better legal thinking here on this call, what essentially said that is, by definition, an organization, a parent organization that has control over a subsidiary, those two, the parent and subsidiary, cannot be considered competitors. They're really one and the same. So by meeting the Copperweld test, what that means is you're able to achieve full integration, and you're able to do things like collective contracting. At least in Geisinger's case, really probably the main focus there would be on all their supply contracts and how they might evolve to eventually fill in some of that gap, that geographic gap with other affiliations. So that's the short answer, maybe the non-legal answer related to the Copperweld test.
Great. All right. Well, Andre, we have a couple of questions that have to do with any creative affiliations you could talk about that involve non-hospital or non-health system participants. So one question is, if you could comment on any creative affiliations with innovative primary care organizations or non-traditional partner types, particularly to focus on bolstering health.
From our experience, I will say that, yes, this dynamic is going on with other sectors, not just health system to health system. I think the real driving force behind that is you could probably tell, I can speak to directly the Geisinger transaction. It took a lot of effort, thought, and creativity to kind of come up with a deal here that made sense for both parties. There was no template. It really started from scratch and really evolved from those goals and objectives we talked about, and a lot of countless hours and meetings and really making sure that we knew each other's objectives. From my perspective, the short answer is yes, these same concepts could be transcended into any other sector. The real question is, do the parties have the motivation to invest all the time and resources to to negotiate something structured like this relative to the overall benefit. So is the cost of kind of investing the time and brain power or is the cost justified by the ultimate benefit? I think from a practical standpoint, that's the way I view it. And from my real world kind of perspective, some of the deals that I'm working on right now, in particular on the post-acute side, I could just name one example. So on the post-acute side, many of the historical home health transactions with health systems involved home health agencies being purchased outright and maybe having some looser clinical affiliation going forward. Or there's a situation where, yes, there's perhaps a 80-20 split in terms of a joint venture, but the health system really doesn't retain any kind of meaningful governance or control of things going forward. What I'm seeing right now is that there are some home health companies that are willing to partner with health systems in a minority position, which I think is pretty novel. That creates a system, that creates a dynamic where the home health provider with all the expertise is going to come in and really not have full control. And the reason for that is the health system believes that the home health agency is a very strategic asset. They want to retain control, and therein kind of lies the rub in terms of why you need a creative affiliation. A lot of structuring went into that particular deal. It's still not finalized. I can't announce it right now, but needless to say, the overall benefit from the health system perspective and also the home health agency, they both felt that it justified the overall cost of advisors and otherwise, and just management time to be able to invest in that particular transaction.
Great, thank you. You anticipated the part two of that question was going to be directed at post-acute care, so thanks for covering that. We have several other questions. One is whether you're aware of or anticipate any other Vivity type models in larger metro areas.
Thanks for the question, Rob. I think, you really have to look at the markets right now that have some of those same structural elements. So if you have a geography perhaps that is still fairly fragmented, if you have a situation where providers are able to kind of come together and there's a greater purpose, if you will, to either capture a large employer market, that's one example, or perhaps capture a statewide contract, a Medicaid contract or a state employee contract, that might be another example. Where again, providers are able to kind of put past some of their differences in terms of being able to reduce their fee-for-service rates, normalize those rates across the provider network in an attempt at least to provide the most competitive price to the ultimate payer. From my experience, I've seen some remnants of this trying to occur in other markets. It's been somewhat difficult. I can name one specifically, some of the work I do. I do a fair amount of work in Ohio in particular. And there are a couple organizations that were set up for this purpose in terms of thinking about longer-term statewide contracts, one being Health Innovations Ohio, involved several of the very largest health systems in the marketplace. And one of the ideas behind that was they were going to be able to collaborate and offer more of a statewide product. And in particular, in that marketplace, really wasn't focused on large employers that needed the real breadth of the network, but really the state employees. And unfortunately, for a lot of different reasons in that particular market, that really never came to fruition. Health systems were not really able to kind of come to terms in terms of many of these same elements that I just described in Vivity, and for a whole host of other reasons that I'm really not aware of. But at least in the net result has been, I think one of the ultimate goals was to try to get that statewide contracting, and maybe it might evolve into that going forward. But as far as my knowledge is, nothing has come of that in terms of those providers being able to band together and offer something similar to Vivity.
Great, that's very helpful. We have another listener who is asking if you could comment on special challenges in states like New York that do not permit for-profit health systems to operate.
That's a great question. In terms of, I guess you kind of, you separate that out, the creative affiliations concept between each of the provider types. So in terms of the health system types, most health systems, in terms of just looking at the overall landscape, and it varies by region, obviously. Perhaps Florida and Texas have some of the highest concentration of for-profit providers. Obviously, New York has the least, given some of the prohibition that occurs with for-profits operating hospitals. I'd say that it really depends on the providers that you're talking about and what the needs and goals are. So if you're talking about New York and there really is a need for capital and some other kind of backstop in terms of financial risk, well, oftentimes for-profits make a very good candidate for doing something like that. So unfortunately, you're not going to be able to take advantage of that. But perhaps in a different type of vein, in terms of other providers that are not necessarily prohibitive by the for-profit legislation, then you're able to kind of continue on that path in other different sectors to focus on some of those elements. But the short answer is, at least when it comes to the health system side, with the exception of some markets that are really have a large proliferation of for-profits, I would think that the same concepts in terms of health system to health system type transactions and having more of this creative type affiliation mantra associated with it should still be able to be done, at least in like states like New York and perhaps others that don't have as many for-profits.
Great. Well, we will try to squeeze in a couple more questions. One is just another definitional question. If you could explain the concept of member substitution.
Sure. What I mean by member substitution is in the not-for-profit world, in terms of doing a fully integrated transaction, or one that's kind of tantamount to a full asset merger, or as folks kind of think about it, your real options, there's various ones, but one of the most common ones is a change of corporate member. So if, let's just kind of use this simple example, Health System A is looking to affiliate with Health System B. And this is actually exactly how the Geisinger transaction worked. So what happened there was Geisinger became the new corporate member, if you will, of AtlantiCare's parent entity. So before the transaction, AtlantiCare was a not-for-profit without a member, so it was a non-member not-for-profit. So what happened then after the fact was that Geisinger became the new member, if you will, the corporate member of the AtlantiCare parent. And while not completely similar, kind of think about it as almost a parent-subsidiary type relationship. So the change of corporate member is, as far as from a practical standpoint, you can think about it as the target, if you will, becomes a subsidiary of the entity that's, lack of a better term, acquiring, or the lead partner in a transaction.
Thanks. And we have just time for one more, so let's pick one that's a little more general in nature. You've emphasized the concept of collaboration. Can you say what the early signs are that there is positive collaboration and cultural match between two organizations seeking to partner?
Thanks, Rob. I appreciate that question, because that's frankly, aside from the structuring, which obviously is very important, that's probably the number one concern is, is there the fundamental ability for organizations to come together and have, the innate trust that's necessary to start thinking about deals that are a little bit outside the norm. I'd say that the key element of that is really making sure that two organizations' visions are aligned. So what I mean by that, and I'm going to use the Geisinger deal as an example. AtlantiCare had a very strong point of view about the future of healthcare, that they really believe that it will all evolve ultimately to risk-based reimbursement. AtlantiCare and health systems will be increasingly more responsible for the health of their populations, and no longer will the hospital be kind of the center, if you will, of profitability. It's really all about kind of managing lives and thinking about your health system as more of a healthcare company. And that was a perfect match for Geisinger in terms of how they thought of the world as well. So before we even talked about all the detail about, how the partnership would get structured, or detailed goals and objectives, that fundamental alignment, if you will, between the executive management of Geisinger and Atlanticare, and also the board or the governance level alignment between the two organizations was really critical to get through some of the structuring elements here, because again, they were all in it for the same thing. They all wanted the same end game, and philosophically everyone's aligned.
Great. Andre, thank you very much. I know the listeners appreciate your time and your expertise, and we appreciate the listeners devoting their time to this webinar. If you have questions, please don't hesitate to contact Andre. The contact information is at the end of the slide presentation, and look for the email coming soon with a link to the recording of the presentation and other materials. In the meantime, thank you very much and have a great day.